All righty, here we go. Welcome everybody to Vent Rounds, SEVA VentRounds. Today is March 22nd, 2022. We're gonna do a new version of Vent Rounds in which it's hybrid. So I'm sitting here with our fellows in the room, and we're just gonna go through some of the screens and shots that we have done before. So here we go. First, the disclosures. We discussed particulars of ventilator modes. There is no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I received some fees for books and chapters and co-owner of a patent with Rob, and you can see here the conflicts of interest of Rob, and also receives fees and royalties. This is a recorded session, so keep your microphone muted, and I may call upon members of the audience to comment, or if you want to comment, use the chat function. Rob is checking the chat function, and we will be happy to call you in to comment. So this is actually a case that Arvind Menon sent me via Twitter that I thought that it would be interesting for us to review. And on initial appearances, looks like it is. So I would ask anybody wants to take a stab at it and read it. Okay, go ahead.
So for the tag, seems like the flow is strictly controlled. It seems like volume control would be the control variable. Don't see any color change unless I'm missing anything that would otherwise indicate patient activating the trigger. I would say this is all mandatory and CMV at that point. CVS.
Okay.
In terms of the load, I feel like patient is fairly passive for inspiration.
Louder.
I see that the patient is fairly passive. On inspiration, the majority of the load needs to be. The pressure waveform is kind of. It looks like resistive, but the time constant is. I think it's all normal.
So elastic, resistive, or PMAS? Choose one of the three.
Elastic.
Elastic. All right.
The exponential return of the decay of the excitatory waveform, I think, mirelee elastic.
Okay.
Of the PB discordance, there are no patient trigger. I don't see any drop in pressures prior to the trigger of the breath, so I think it's normal. I don't see any work shifting in inspiration or expiration. Fairly passive patient. Don't see any cycling discordance or any cycling.
All righty. So everything's normal on this. Any comments, disagreements with the fellow? No. So let's take a look at it. So indeed, I agree with you. The volume control, it's volume control because the flow is controlled, and that's a common misconception. And actually, you can see here that it says adult and ACBC. That's the way that this ventilator controls the or the nomenclature that they use. They say ACBC, but in reality, what it means is that it's controlling the flow to deliver a given tidal volume that was set here. You can see it says 410. You are absolutely correct. Just by the fact that every single breath the flow is controlled, it becomes mandatory because you're controlling the start and the ending of the breath. And in this ventilator, there's no other intelligence into the mode or into the targeting, which makes it a set point by itself. So absolutely correct. Rob, any comments or disagreements so far?
No comments other than when you have a descending ramp, it seems to be set so it goes down to 0. Again, as we've mentioned many times, that this is good for evaluating mechanics because the initial pressure is all due to resistance, and the final pressure is all due to elastance, which is a good approximation of plateau pressure without imposing an inspiratory hold on the patient.
Excellent. Thank you very much, Rob. Actually, that takes us to the load, what you were talking about. You can see that the flow is the highest at the beginning, which means that the resistance is constant through the breath, right? So if you, in this curve that I have put here, I have put how would the resistive load would look. And so you can see that at the beginning, it's mainly resistive, but at the end of the breath, when there is no flow, it's all elastic, right? So this gives you an idea that essentially at the end of the breath, the pressure is higher, which goes with an elastic load. And then, as you mentioned appropriately, the time constant, the time that you return to baseline, is short, so it's within 1.5 seconds or less, which also speaks towards an elastic load. Do we agree? Questions, disagreements, anger management? No. All righty. And then the second question that I have for you is, do you see any PMOS? Anybody sees PMOS? No. So if there's no PMOS, essentially the patient ventilator discordance is gone, right? So there's no PMOS. Now, is there anything abnormal of this screen? You're like, Mireles, this is the most boring screen I have ever seen in all VentRounds. Is there anything abnormal? Anything that catches your eye? Have no fear. Rob, if anybody has put anything on the panel, on the chat, please let us know regarding what's abnormal with this waveform.
The exhale tidal volume is reading lower than set.
There you go. Thank you, Aman. So you can see here, the tidal volume is 368 and the set tidal volume is 410. Isn't that psychotic? So now you have a difference in tidal volume expressed here. Evidently, you don't know how much it's going in. There's a screening which you can see the tidal volume that has been inspired. But in other ventilators, and that's why I put screens and scales, in other ventilators, you can see both the inhaled and the exhaled tidal volume. So there's a discrepancy in tidal volume. Very good. Why would you have that? What's the most common cause?
Have a leak.
So I heard auto leak. Sorry, auto leak. Air trapping when it occurs rapidly, that can also cause a discrepancy. Any other? Rob, do you have any other on your chat?
Nothing came in. I will say that air trapping doesn't cause a discrepancy at steady state, only while it's accumulating.
Right. Exactly.
And
just at the beginning, then it reaches steady state.
How about if there's something with the flow sensor?
Okay. The difficulties with the flow sensor, issues with the flow sensor, Rob. What do you think about that?
Not on this ventilator, probably. I believe this is a Puritan vent at 980, and they don't use a proximal flow sensor. It's an internal flow sensor, and if that's shot, then it needs to be recalibrated.
Very good. Very good. Any other comments on the chat before we move on?
BTPS not achieved. Circuit compensation off.
Yeah, excellent. So, Rob, do you want to comment about those three items?
That's an interesting thing about circuit compensation. Yeah, I suppose I'd have to think about how this ventilator works, but circuit compensation means that the ventilator puts out more to make up for the volume that is compressed in the patient's circuit during inspiration. And that would indicate, I mean, without that being there, then you would always exhale less than the ventilator put out. So that is a potential. That's a very good idea. BTPS not achieved, not likely. Even if you just had an HME, so maybe if you had a patient on without anything, possibly, but I doubt it. I don't think that's it. What if it is a proximal sensor, flow sensor? I don't believe you can have a proximal flow sensor on this vent. But I'm not sure what the vent is. I think it's a 980.
It is a 980, yes.
And I think if there's a flow sensor, it's only for neonates, if they have one. I'm not sure.
So thank you. So we have highlighted a couple of causes for you when you have the discrepancy, and this is a common thing at the bedside, right? They call you, there's a discrepancy, and you're looking for the leak like crazy. Is the compensation on, or is there an issue with the sensor?
What is BTPS?
So BTPS, Rob, do you want to talk about BTPS?
Yeah, it stands for body temperature and pressure saturated. All ventilators, all modern ICU ventilators assume that the gas going into the patient is going to be heated either by a humidifier or by the patient themselves, which means that the volume of gas increases, and not only because of the temperature expansion, but also because of the addition of humidity. So in other words, if you want, let's say 500 mLs to go into the patient, then the ventilator knows that it has to deliver 480 or something like that. So that's around 10 or 12% difference. So that the monitored values and the delivered value to the patient in volume and flow is what you want. And you will notice, and it's interesting that this comes up because I've just now reviewed a paper where people were trying to compare the accuracy of the ventilator's flow delivery with, let's say, what the ASL says or an external monitor. And if you don't have both sources corrected to the same conditions, body temperature, pressure saturated, or atmospheric temperature and pressure dry, there are four different ways to do this. Then the errors or the differences you see in the measured volumes are only due to calculation errors and not due to actual delivery control errors.
That system bypass and pressure control, or is still?
So the question is that bypassed on pressure control, Rob?
No. Well, in pressure control, the ventilator controls pressure, but it's going to display exhale tidal volume, and it has to correct for that, or inhale tidal volume for that matter. So if the ventilator is measuring volume in any way and monitoring it or controlling it, it will generally correct to BTPS. Now, one difference that you might run into is the servo eyes. There's still some of them around. They corrected the standard temperature and pressure dry. So if you compare a setting on a servo eye with a setting on a servo U, you're going to get different differences delivered to the patient.
Fantastic. Thank you. So you can see how a simple image has a lot of information just for us to discuss. So this was actually the image that came, and I thought that it would be interesting to talk a little bit about it. On one side, you have an inspiratory pause maneuver, and on the other side, you have the expiratory pause maneuver. Same patient, same settings. You can see still the discrepancy on tidal volume across this. So who wants to talk about this? What do you see? Anybody?
There's depressurization during pause, which is supposed to be a zero flow state, implying that there is flow and possibly a leak.
Exactly. So the flow, the pressure, you would expect there's always some decay as it relaxes or as it comes down and it dissipates. But this continues to go down throughout the inspiratory time, and you can see that it was the amount of time that the patient spent in that inspiratory pause was around 9 seconds or 8 seconds. So throughout that period, it continues to have a drop in pressure, and so what causes that would be one, a leak, as you have identified. Anybody else? Any other cause of why this leak would be there, or why would this go down?
How about a leak with the patient himself, like a bronchopure fistula?
So a type of leak. So the circuit is not closed, right? So it's not maintaining the pressure in a zero flow, and that should be because either the cuff is leaking, or there's something is not tied up on the on the circuit itself, or there's bronchopleural fistula or a pneumothorax that is leaking out outside. Very good. And so you see that drop in pressure, and then you see actually the expiratory pulse maneuver. What do you see there?
Going below that peak.
So the pressure continues to drop after we do the expiratory pause, right? So it's not a constant pressure. You can see actually how it's dropping during the peak, which very nice in this display of this ventilator. It makes it very evident to you. Rob, any comments there?
Nothing that you haven't discussed. There was a mention of pendule left stress relaxation, tidal recruitment. Those are all things that you'll see immediately after the inspiratory hold, but they should plateau.
Exactly. So they should go away relatively rapidly. The other item that it's interesting, and that was the question of what were these lines over here, right? These oscillations. So any comment there?
Yeah, very cardiac oscillation, likely the cause. That case, it's about the rate of maybe.
Good. So you see the regularity of these oscillations, and in a patient in which you have so this is a common thing that you would see. Obviously, in this patient, if there's a leak, but usually you see the frequency change as the leak occurs. If you have no movement, so meaning there's no flow, can there be secretion movement? No, right? So that makes it more likely to be the case. Now, one of the questions that came up was why are they so visible here? And you can see the scale is exactly the same, 0 to 35. And you can see on the other side, it goes 0 to 35. Well, this one has -5, but you can barely see the oscillations, but you see them, right? You can see how they are there. Why is that a difference in transmission?
Lung versus
The diagram push that the inspiration.
Where do the cardiac oscillations come from? Go ahead. So what structure is right ahead of the bronchi and the left atria too, right?
Right.
So as that's increased, it creates oscillations on the airway, on the floppy area of the airway, and that's what gives the oscillations. So if you inflate the balloon better, right, and now you have more opposition against the structure, you're going to transmit better the oscillations. So that's, I mean, nobody has proven this, but this is a theoretical construct for it. Rob?
No comments that we haven't discussed.
Excellent. Any comments on the line? Yeah.
Like this came up with COVID a lot, but in these patients with like unresolvable leaks, and you're trying to get like a plateau pressure, how is this completely unreliable now? Do you just go after like the very first thing? You know, how do you?
It's very hard, right?
Reconcile it, yeah.
I'll ask to the audience, how would you, can you measure plateau pressure in a patient that has a leak? Huh?
Yeah, I was just saying that if you have a huge leak, it'll be difficult to do. But in general, I do very brief pauses, like 0.3 seconds, for the aforementioned reason. But also, if you do a very short pause, then the leak would be much lower. So I always check on the volume waveform. If I get a lot of leak, then that reading is not probably accurate. But if I get a very little leak, then probably I'll trust that reading.
Let's see. Rob, what do you think?
I think that's reasonable. Looking at the volume waveform would make some sense, I guess. Yeah, because you could lose pressure but not lose much volume, and if you're trying to assess compliance, you know, that's where you'd want to look. It's reasonable.
So in this patient, let me ask you the following question. Can the plateau be higher than 30? Aman, you sent me a paper about this. Do you want to comment?
Sorry, can you repeat the question?
Can the plateau be higher than 30 on this patient?
On patients with leak?
And this patient in particular?
Oh, yeah. I mean, um, I guess it can be. I guess if you're asking the plateau be higher than peak pressure, is that what you're asking?
In this patient, yes.
It can be higher. I guess if the patient has been very active. But in this particular case, no, because the patient was very passive. So the plateau should not be higher than peak. But if there's a lot of PMUS during inspiration and that PMUS is let go during the pause, then it is possible then the actual sort of distending pressure of the lung is revealed during the pause. So if there's a lot of PMUS, then your plateau can be higher than peak.
Very good. So in absence of PMOS, in a descending ramp, the plateau cannot be higher than the peak pressure that you see there. Does that make sense? All right. Very good. Okay. I have another one. Any comment from the prior one, or should I move on? So very cool case of a leak and cardiac oscillations that we were unable to see before. All righty. Anybody wants to try this one? Have no fear. Nobody's name. Anybody wants to try? All right, Mo.
So it's pressure control. The pressure seems to be the controlled variable. So I guess we have the pressure waveform, volume waveform, and then esophageal pressure and the transpulmonary pressure tracing.
Yes, it's in Spanish, so that's why you see it in different. Sorry.
So the fluho is different.
Yes.
So
Yeah, that's flow.
Pressure control. I don't know if I'm to anticipate. I think the cycle times, maybe it's different. It's hard to see with the scale.
Yeah. Say it loud. Have no fear. CMB? All right. Why do you think it's CMB?
Because like the third breath, the flow.
Okay.
Patient triggers. I think it's same.
All right. So and the tag, what do you think? Yes. All right. So set point. So let's talk a little bit about it. So you see the pressure is the same height on every single one of the breath. So I agree with you on the flow, just as you said. Every single one of them is different. What about the triggering? Who's triggering? The machine or the patient?
So he drops, or they drop their pressure, their esophageal pressure before, right? Or the transpulmonary pressure drops before the breath.
So great. We're gonna come to this. Forget about the esophageal pressure for a second. Come up here. Is there any marker that tells you that the patient triggered?
Pressure doesn't drop, but you can't expect that because it's pressure control.
Excellent.
And the flow expected to like ramp up before.
Crossover. Well, you cannot see it very well. The scale doesn't let you, right? The scale is up to 50 liters. But the ventilator, this ventilator always tells you where when it's triggering. And the triggering is this little triangle over here, this sad triangle over here. So you see this last one, actually you can see the pressure dropped. You see that little dimple that it dropped, and it comes with this one. The rest you don't see that, and there's no triangle. So all of them are machine triggered, and if they're machine triggered, they immediately become into mandatory. So this is CMB, and S is the so good job in the corner. S. All right. So what is the load? Is it elastic, resistive, or PMOS during inspiration? So I hear a PMOS on the corner. Do you agree? All right. What about the exhalation?
Some elastic, some
Elastic. All righty. Is there one of these breaths that tells you that this is more elastic? The first one? You're in for the first one. First one wins. Okay, elastic. All right. So PV discordance. Just looking at the two top graphs. I left the esophageal pressure because it's going to help you, but look at the graphs on top. So let's start with trigger. So is it normal? Meaning every time the patient asks for the breath, it triggers the breath. Is it early? The ventilator goes first, and then goes the machine. No, sorry, the machine goes first, and then the patient. Late, the patient goes first, and then the machine. False, this is not triggered by the patient at all. Or is it failed, meaning the patient did the effort and it didn't trigger anything?
I guess we can only judge the last breath, right?
You have all of these. All of these are your friends. Have no fear. What is the predominant pattern that you see here? So you know that all the breaths are machine triggered, right? Yes?
Yeah.
So those are all machine triggered. And then after the machine is triggered, do you see evidence of PMOS? Yes, you told me, Eduardo, the dominant force during inspiration is PMOS. But is it triggering the breath? No. Huh? Say it loud and with pride. It's an early trigger. Yes, exactly. It's an early trigger. So the machine is triggering, and then the patient does effort, and you recognize that here and here, these little divots that you see. This one it didn't. This one is looks passive. This one, then this one over here, you see that this is passive, passive, and this is a little bit activated. And actually, so I thought that this was very useful. Okay, this is early trigger, but look at the waveforms down here. So let's interpret the esophageal pressure, right? So the first breath, you said there's no PMOS. You choose that one to say that that was elastic load, right? And you can see how it's an exponential, beautiful decay. I mean, this one is like out of the book. And look at the esophageal pressure. What does it do? It rises, right? As it should, because there's the pressure is going in, and so the pressure goes in the next one. You see the ventilator triggers and the pressure starts going up, and then what happens? It goes down, and you see the change that tells you that this is PMOS. And then it cycles off, and it goes back to baseline, right? The next one is even much more pretty. Again, the pressure goes up at the same level as the first breath, right? So it was passive. And then the patient early triggers, and you can see the flow increases, and immediately the esophageal pressure is going down, and you can actually see this little format here that tells you that it looks like a early cycle, which is the classic combination with early trigger that you would see. And that's the way that you should expect to see that. So, and you see the next one, and the next one is identical to this one. This biphasic kind of it's pressurizing, and then the patient does the effort, and it drops the pressure below baseline. The next one is passive too. Look how this one and this one look the same, right? The third one, there's a little bit of PMOS that activates. It starts, and actually you don't see this go up, which tells you that the patient was doing some effort. It was probably earlier activation of the reverse trigger. The next one is the classic, like this one. The third one is passive. And the last one you see how the patient triggers the breath, so it drops the pressure, but it's a little trigger. It's like, and it triggers the breath out, right? So you see how what you were reading on the waveforms up here, the esophageal pressure helps you to do that, but necessarily you don't need completely all this information. It's added, but it helps you understand that this is an early trigger or reverse trigger, as they call it in the literature under these circumstances. It can have
There's a
different
good comment here, a question by Ariel. Go back to the last breath. He says, why is the only breath triggered by the patient have the smallest esophageal pressure deflection, but the highest transpulmonary pressure?
That's a good question.
Yeah.
Also have the highest flow, which under like it's surprising that it has the highest flow.
We can't hear the comments in the peanut
Can you
gallery.
say it loud?
Oh, I'm saying it also has the highest flow, which is surprising if that's the least patient effort compared to the other breath. Why would he also or she also have the highest flow compared to the other breathing?
Well, why do you think it's the lowest inspiratory effort?
I mean, based on the esophageal pressure waveform.
But you don't see the climb that you see in the passive, right?
Yeah, correct.
So all that is
The lack of the climb.
the lack of the climb is the patient is doing the effort, and the ventilator is just demonstrating this amount of support on the patient, if you may, right? So the patient is getting much more flow because he's activating now, coordinated with the ventilator, and that's why the flow changes so much, right?
Yeah, so remember that the esophageal pressure will drop because of the patient's effort and will rise because of the ventilator's work. So the reason why you don't see a big hump there is because the force generated by the ventilator is being counteracted by the negative going esophageal pressure by the patient's effort. And in total, you get a higher transpulmonary pressure, which is what gives you the higher inspiratory flow.
Fabulous. Any other comments, Rob?
No, that's it.
That makes sense. Good.
Excellent. All righty. Any other comments on the chat?
Nope.
All righty. So does this help? Point this. Very good. All righty. Here's another one. This is another gift. Also, it's in Spanish, courtesy of Luis Fernando in the National Institute of Respiratory Diseases in Mexico City. He shared this with us. So anybody wants to give it a try? Oh, and so I just want to do a mention. One of the challenges with at least this ventilator, and please anybody of the experts on the online or Rob, is that in this ventilator you can change the scale in terms of time, but you cannot change the scale in terms of the numbers that are over here. So of
The vertical axis? You can't
Yes,
change the vertical axis.
you cannot change the vertical axis, which I think that in my eyes it just generates a little bit of discomfort, because then I cannot see sometimes things that you would want to see just by amplifying the scale.
Very good.
Question on this one. The reason we are seeing this early trigger is because the frequency is too maybe higher than the neural frequency of the patient, or is it because why would the inspiratory effort be out of sync? Is the trigger sensitivity so high? But if that's the case, why a minimal drop in esophageal pressure would trigger a breath?
Yeah, that's a great question. I think that we're still learning what causes that particular. So within all the early trigger causes, right? So there may be early triggers that it's just one event. It's not a reverse trigger. It's a hiccup or somebody poking me on the side or whatever other etiology that you want. There's a subgroup of patients that have what we call now reverse trigger, that particular pathway, which talks about the neural conduction. I mean, something in which triggers and either by stretch receptors, displacement, it generates the signal to the phrenic nerves or to the medulla to generate a contraction. I think that there's things that that facilitate it from occurring. And there's two different types. There's the one that you can actually drop the rate and it will continue to occur. that it's kind of a reflex state. And there's others in which, as you go down, the natural rate of the patient takes over and it goes away, right? So I am not entirely sure that we have an answer right now, but I mean, actually, they just published a beautiful article on pigs with a model, the first model for reverse triggering. And so trying to see the effects on the diaphragm, because we don't know if that hurts the diaphragm or not, and what are the effects. So it's in the Blue Journal, and I can send it to all of you after this. Very nice.
Another observation that we didn't mention is the early trigger in a couple of breaths leads to early cycling as well. If you look at the 8 and 10-second marks.
Yes.
But I think from a nomenclature standpoint, we agreed that we're gonna just call the primary phenomenon that's driving the analysis of the waveform, right?
Yes.
We're not gonna call
Yep.
know that one is leading to the second.
Yes.
Let's call this an early trigger, early cycle.
Just call it early
trigger.
We wouldn't call it early cycle, because
Exactly.
we know that inspiratory effort happening in expiration is secondary to the early trigger, not secondary to early cycling problem.
Excellent. So the point being, in terms of taxonomy, how would you classify it, right? I do think, and talking to about what Rob is saying, and this has also been published by the group in Boston, is the differences in where the early trigger happens. It can happen, and you actually have here different types. You have one that occurs very early, one that occurs almost at the end, and we don't have one which happens during expiration. That we may talk about the neural time and when do you reach that threshold to trigger it. But if you think about it, there may be different consequences of each one of them. In some of them, you may get larger tidal volumes. In other ones, you may get eccentric contractions in the patient. So these, the ones that come with early cycle on top of that may be worse, or if you're triggering and getting a breath stack at the same time. So I don't think that not that I don't think, I know that we don't know what are the consequences of this. You're living in the early phases of knowing what is the cause and how are we going to deal with it. Rob?
Just another argument for using spontaneous breaths instead of mandatory breaths.
Yeah, that's right. All righty. So who was going to read this one? Anybody wants to give it a try?
That's right.
All right. I mean, loud and powerful. Okay.
So looking at the waveforms, I think the pressure waveform is more controlled than the flow. And I go with PC for the control variable. Looks like all the breath, for the most part, looking to be, well, at least they are triggered by the machine. So that makes it CMV. Looks like it's set point. Well, let me take a look at the settings here. We have a tidal volume that is set in, but I still believe that this is pressure control. So I'm just going to say A. And this might be an adaptive. Don't see evidence of adaptive on the waveform, just because of the settings of the waveform. Now, in terms of the load, I think it's PMAS during inspiration. I think during exhalation, I'm leaning towards elastic.
Okay.
Now, in terms of trigger, if the flow waveform is truly, if I'm right with the control variable, it looks like it's passive at the start of the flow waveform, and then at one point we get a hump, like the evidence from the PMAS. So that means that we started passive, and then the patient got engaged. I see evidence of that on the pressure waveform as well. So I'm going to go with early trigger, with the vent triggers before the patient's effort kicks in, hence the name early trigger. Inspiration, some work shifting that is minimal. And then cycling wise, I don't see any evidence of early cycling. And if there was, I know it's related to the trigger, so I'm going to go with normal. And then exhalation, I don't see evidence of warm. So I'm going, although the last breath, maybe, but normal to minimal. Now the other waveforms that are there, but there's a volume waveform. Interesting. So that's the inside of waveform, but on the vent, there's a pressure volume.
To volume.
Like a volumetric kind of, yeah.
Yeah. Very good. All right. So let's start by the meat, right? What is the mode? And obviously, you're practicing in Mexico, so you have it's in Spanish. So it says CMB, and you're like, what is that? So you go to the Rosetta Stone and you look for it, and it's going to tell you that it's volume control. And it's just the regular volume control is volume control CMB. Yes. However, I know why you went there, and I want to talk a little bit about it. So what happened here is you look at, and that's why I placed this one. You looked at the pressure waveform, right? And you see the deformation, but we know that ventilators are not good pressure controllers, so deformations are common even if you're pressure controlling. But you saw the flow waveform and you said, this doesn't look like a geometric shape, right?
That's exactly what happened.
So the question is, why is Eduardo lying to me? Why is the waveform not a beautiful square, a triangle?
There's an element up there that related.
I'll cross it off for you too. Not there.
You know, if this was a servo U, I would have been like, this is, circuit compensation. I'm not aware of this function and what it leads to in terms of waveform on the Hamilton.
That's beautiful. So you just highlighted that sometimes we get sabotaged by the ventilator. So the servo U will put a waveform that simulates how it would look at the Y, right? If the sensor was at the Y, where is the sensor on this ventilator?
There's a proximate sensor.
It's in the Y, right?
Okay.
So changes if there's changes in the compliance of the tubing on the flow, even though the ventilator just gave that flow, your pressure is going to drop. You're going to bring some, and you're going to see an increase, some amount increase in the flow that you see on the waveform. And actually, if you go out and see our ventilators that are in volume control, you're going to see that. And it's certainly disconcerting, but it's just because you're where the proximal flow sensor is at. Does that make sense? So that's why you see the flow increase as the patient does effort, because there's some of the circuit that is crossing through that sensor, and it gives you that image. Rob, disagreements, anger management, slap?
Well, yeah, I think that flow deformation is probably the patient sucking gas out of the circuit, even after the vent doesn't want to give anymore. And the way you can tell that is, if you look on the tidal volume display, hardly any volume is associated with that flow distortion. And the distortion in the pressure is way bigger than the distortion in the flow. So all these things lead you to believe that this is volume control. And this is another perfect example of how a name of a mode gives you zero clue as to what the mode is actually doing, which is why we need the taxonomy. This actually stands for synchronized, continuous, mandatory ventilation on a Hamilton ventilator.
I think I would still stand with the PV discordance though being exactly the same. But still the pressure wave deflection and the fact that the patient is sucking across the circuit. And this time in the breath versus, where the breath starts would mean that the rest of the interactions are exactly the same.
Excellent. So now you can imagine if you think about this patient, you said he has early trigger, right? Compare the prior one with this one, and the level of irregularity was huge. in this one, I mean, this you can, and we see these patients now and then, they're sedated, they're out of the, or they're coming out, but they're practically not doing anything, and it's just following each one of those. So that's why I think that there's a degree of neurotoxicity from our sedation that is going there, that is causing these patterns of uh, of activation of the muscles. Very good. Any other comments that came out on the chat, Rob?
Yeah, Ariel made the comment that no ventilator is a perfect flow or pressure controller, and he would consider this to be a reasonable flow waveform, even though there's a slight amount of distortion.
Well, I would counter that what the images that we have seen on the lab, the ventilator controls very well the flow. I don't know what you think about that versus the pressure.
Well, you have to make a distinction also as, first of all, I agree, yes. They control flow very well. They do control pressure less well. And what you want to make a distinction is between the flow that's being controlled by the ventilator and the flow that's being displayed as measuring.
Yes.
So yeah, you can have a perfect rectangle or perfect triangular shaped flow waveform coming out of the ventilator, but because of the way the flow sensor works and the fact that the patient can suck the extra flow from the, the compressible volume in the circuit, then you guys, in other words, the displayed measured waveform is always going to be different than the delivered waveform for a patient that has PMS.
Excellent. Perfect. Thank you, Roberto.
You're welcome.
All right, I have another. This one is a treat. This one led to a publication, actually, and a complaint. So here you go. You want to read this one?
Isn't it the crickets?
I want to know what you see.
Okay.
All right, you're gonna try it?
I can give it a try.
All right. Go for it. Have no fear.
I'm always there. I don't see a strict flow control, so I would call the control variable being pressure.
Uh-huh. And you can notice I put all the variables on the screen, so I didn't want to hide anything from you. No sabotage today.
I think I don't see a color change precisely, so most of the breath
Oh, sorry.
appear to be machine triggered. Definitely make it all. Don't see any breath to breath variation. Second wave has some flow variation. Most part it looks set points. I will say PCC.
Uh-huh.
Pretty hard. The tricky part is the load. I do see that during inspiration there's this bending of the concave flow waveform, and that would indicate that there is some distortion happening. So I would say it's PMA.
Okay.
Expiration, I don't see a beautiful decay. I actually see some active isolation, so I'll call it PMAS as well.
Okay.
In terms of trigger, now I'm not sure. Says it's a 3 centimeter water pressure trigger, and the pressure is dropping, but the machine is failing to trigger the breath, and that is followed by a patient effort. So I'll call it an early trigger.
Early trigger?
Yeah.
Okay.
Not very confident. I'll take it back. But that's how I see it. I mean, there's a pressure trigger said, I don't see a color change unless I'm not.
This one doesn't color change.
Feels like a.
No, it changes. It puts here either if puts a C, that's controlled. If it puts an A, it means assisted. It means that the patient triggered, and if it's
assisted, so I mean it's triggered. So I'll take that back.
Okay, so he recants. Okay, what do you call it now? Normal? You have killed early, late, false, or failed?
I think it's in line. I think it's in line with how the drop in pressure is causing the start of the flow for at least these three breaths. Might be a little late, but they seem to be in sync. I don't think it's false. There's definitely drop in pressure. So I'll call it a normal trigger.
Normal. Okay, he goes for normal. All right.
Inspiration, I definitely see some work shifting. It's not crossing the baseline, so I won't call it severe.
Okay.
Cycle-wise, supposed to be the time cycle.
Uh-huh.
Cycling for the most part. So, but I think it's cycling early because the inspiratory requirement sort of continue in the patient is sort of trying to suck in the or actively. I think it's actively inhaled. I will take the poison. I'll say it's normal cycling. And I see expiratory work shifting.
All righty. Expiratory. You're gonna love this, and you're gonna hate me.
I never hate you.
All righty, here we go. So it's definitely pressure control. Excellent. And I put all the settings up here just for the eyes. It is CMB, but the reason it's CMB, it's not because the patient is triggering every single one of the breaths. So it's mandatory. Every breath is mandatory, not because the patient is triggering, but it's because cycling, right? So that you can see, and you recognize that there was a problem with the cycle. So the cycle, the breath, the patient is ending here, and the machine is ending here. So we'll talk about that in a second. So there is an set point because in this ventilator, in this mode in particular, you set all the variables. You set the inspiratory pressure, the inspiratory time, the rise time, and you set the trigger, which in this case is a pressure trigger, right? So do you see any PV discordance? The first one, let's talk about the trigger. So if you look at so you said that there was expiratory work, right? Mm-hmm. And you see how the flow changes, and then there is this kind of no change in flow, like sadness. Here the same thing, here the same thing, and look how the pressure drops. The cause of that is yes, it's triggering late because we set a pressure trigger, we sabotage the patient. So and the other item, so normally you would have expected this to trigger actually all the way over here. But we also set the rise time on this patient, in which you recognize really well that this is all PMOS. We set the rise time at 50% instead of 100. So this patient requires to get to 3 centimeters of water, and then it will take 50% of to reach pressure. So this is a patient that has a late trigger, right? Is this clear? Question so far? No, we agree. Inspiration, I agree totally. There's work shifting, so this patient is doing effort and he's getting more flow. The pressure doesn't drop below baseline during inspiration, so I agree with you. It's not severe. And then you have cycle, and you went through every single one of the options, right? So remember, if it cycles, the patient ends the breath here, right? And the ventilator ends later. This is late cycle. And you actually said something that was very insightful, right? So you see all that time is patient, the time. So this is a late cycle event. But you said it looks like the patient is forcefully exhaling during inspiration, right? So in other ventilators, you will not see the flow actually cross down. It will kind of plateau. That's the classic image that you have for a late cycle. In this ventilator and others, it allows the patient to exhale, and so all of this flow is now being exhaled, right? So the patient is exhaling during inspiration. So the pressure is high and the patient is pushing all the air out, right? And then the breath ends and the patient continues to exhale forcefully and then takes a breath in. So the patient is actively inhaling, actively exhaling, as you actually recognized it. Now, the important part here, and why this ended up into is this okay? Yeah, I mean, the ventilator is letting the patient exhale. That's fine and dandy. The issue here is this tidal volume here. You see how it says 573? What we found out is, and Rob can probably, Rob, do you want to talk